Yeah, good afternoon, everyone, to this yet another topic of cancer pain management. So, so cancer pain management can be looked at various ways, focusing more on the palliative aspect and as well as the interventional pain management aspect. So, for today, the topic will be focused more on the interventional pain management aspect. I'm Dr. Prashant, working as a consultant interventional pain physician at Elevate Pain Clinics, Bangalore. So the topic will be discussed based on the introduction and then the further different interventions what we do in a pain management clinic for such cancer pains. All right. So coming to the introduction, so pain is one of the most common symptoms which is experienced by patients who are cancer survivors and patients with having cancer. So the prevalence of pain is around 40 to 90%. And most importantly, the cancer pain is multifactorial. So there is not a single one cause which is actually causing the pain, the totality of pain which is actually experienced by cancer patients. And it can and always usually does change over time, that is with the treatment and even with the progression of the primary disease per se. And that's the reason they can have a mixture of nociceptive, neuropathic, and mixed mechanisms causing the pain, which makes it all the more difficult to actually tackle this cancer pain. So you will see why we require different kinds of modalities to actually be treating these kind of cancer pains. So here we see the concept of total pain. Okay, so the pain is not only limited to physical pain, but it also includes psychological pain because of the disease per se, which the factors like anxiety, the fear of suffering, depression, and the past experience of illnesses, which add to it. And then you have a social factors associated with the loss of job or maybe financial concerns, worries about the family, dependency, and loss of role of social status. Okay. And at a spiritual level, also, they will be experiencing certain factors at the spiritual level, which will be adding to the uh, pain experienced by these cancer patients. Will be at the level probably at, you know, loss of faith, like anger at why me is a common question which is asked, why me, and what have I done, do I deserve this? So also they'll be going through all sorts of this psychological and spiritual and social derangement along with the physical aspects because of the comorbid illnesses and caused by the treatment per se, like the chemotherapy or the radiotherapy, and itself caused by the primary disease progressing, meaning to say it can be involving multiple organs, as we know, because of the metastasis. It can spread throughout the body, involving different tissues of the body, and thus causing different kinds of pain in these patients. So, this concept is important because we cannot choose a single mode of treatment for these patients. Like we cannot rely only on medications. Okay, so we'll have to tackle all these four aspects of that patient to finally give them a decent life and and try to be as pain free as possible at all these different levels. So the multidisciplinary system would include the dietitian or the oncologist, the pathologist, radiologist. You can see so many, different groups or different varieties of doctors and non-doctors who are involved, should be involved in the team to be finally be tackling this kind of a complex pain issue. Okay. So coming to the WHO ladder, so this was basically to guide the practitioners to prescribe medications to patients suffering from cancer pain, and also used in chronic non-cancer pain as well. So out of that, 60 to 90% of the patients can be well managed. Okay. So we start off at step 1, that is the pain, with the mild pain. So you'll be using a non-opioid with or without adjuvants. We'll see what are these adjuvants and what are these non-opioids later. So then when it steps up, when the pain is persisting or increasing, we can opt for a opioid, okay, a mild opioid with or and continue the same treatment which they received in step 1. So we can see that the step 1 treatment continues in all those steps, but we are only trying to add other agents. Okay. So in step 2, like it will be including adding mild opioids, and then when there is persisting pain and it's further increasing severe pain, we go to the stronger opioids with this non-opioid or adjuvants, along with the adjuvants. So there has been a change in this WHO ladder. So we'll be seeing in the further slides what that is. So just giving an example of a case of a 65-year-old man diagnosed case of locally advanced rectosigmoid carcinoma extending into the pelvis, causing severe lower abdominal pain and pelvic pain. So as we know that cancer pain is not initially directly jumping into the interventional pain, treatment aspect. So we'll have to be assessing the case and starting them on medications. So this patient was on tablet morphine 120 milligram per day, paracetamol 2 grams per day, and the adjuvants here, like the pregabalin, that is 75 milligram night dose, and the TCAs, nortriptyline 25 milligrams with the pain of 8 by 10 NRS. Okay. So herein where he received this is a possible case scenario what I'm discussing, where he received a superior hypogastric plexus neurolysis. So, and for the follow-up, the patient pain score was 2 by 10 and his morphine dose reduced to 30 milligrams per day. Okay. On further follow-up, he was comfortable for 3 months. So this is just an example to show you that with the help of an intervention, we can help the patient in terms of reducing the dosage of those medications and also giving them a better pain-free period. So let us see the new adaptation to the analgesic ladder. So the same step 1, step 2, step 3 as it was. And now there's a step 4 wherein we include the advanced interventional pain therapies, like it could be nerve blocks, it could be epidurals, it could be patient controlled analgesia pumps, neurolytic block therapies, or even spinal stimulators. And as I said, this also used in case of chronic non-cancerous pain as well. Okay. So this is stepping up, and as the you can also, there is also a step down pattern. So as the patient is feeling better, you can get down the ladder, and again, if there is any increase in pain, you can always step up back again. So the types of interventions could be as simple as a trigger point injection, because you have to remember that in a cancer pain patient, there can be a multitude of pain types of pain. Okay, a single patient can have multiple different types of pain. Okay, because it can include the viscera, it can include the musculoskeletal system, it could include the sympathetic system, the variety of local pathologies as well. So based on that, based on the tissue involved, we could have simple interventions like trigger point injections or nerve plexus blocks or truncal blocks or neurolytic blocks, and we could also supplement with vertebroplasty. And on the other side, we have the continuous or ongoing treatments like the plexus blocks, epidurals, or intrathecal medication, intrathecal delivery of medication drugs. Okay, so let us discuss certain peripheral nerve blocks which you can access, supplement. So here you can see there is a orofacial cancer, malignant, which has included eroded the jaw, lower part of the jaw, and you can see that it won't be isolated involving only the bone. Okay, definitely eroding the bone and involving the nerve component as well. So here it is the mandibular nerve, which is a V3 component, right? So here the intervention done is a peripheral. We have given a block for the mandibular nerve. So this is how we can supplement for the various other treatments which the patient is already taking, including the medications to control his or her pain. Okay. So you can also go ahead with the glycerin ganglion, radiofrequency lesioning, or neurolysis. Again, these are the commonest procedures which are done in the pain clinics under image guidance. Okay. So maybe a patient has, along with the primary symptoms because of the metastasis or the spread of the disease, they could be having difficulty in swallowing and pain while swallowing. So wherein we can also always check for the involvement of glossopharyngeal nerve, and if you think that is the cause, you can always go ahead with the intervention like this, which is again image guided with the with the styloid process as our guide, where you can go for the blockage of the glossopharyngeal nerve. So involving the thorax, the hemithorax, any pain, any neuropathic or radiating pains over there, diagnostic blocks at 3 consecutive levels to identify first the involved nerve. And now we can do a hybrid technique wherein you can use the ultrasound and also the C-arm to guide you while doing these procedures, because patient safety is utmost important, right? So as much as possible, these patients are already suffering. So we should take due responsibility on ourselves to not to worsen their condition or to cause any other cause of any other reason for pain. Okay. So for the safety, no, nothing blind blocks or blind interventions is always image guided. So you can always go ahead in case the intercostal nerves are involved with the neurolysis of those intercostal nerves. You can use phenol or with absolute alcohol more than 50% concentration, and it is whereas phenol is usually used because there is no probability of a motor blockade is not a major concern. So it could involve the brachial plexus where there could be a plexopathy, right? Where the patient could be having shooting pain all around the arm, and it could be very, very, very debilitating to the patient, along with the primary symptom. We did have a patient of rhabdomyosarcoma wherein it was metastasized to the brachial plexus, and the patient had severe uh, radicular pain. When finally we went ahead with the um, first with the initial diagnostic block of the brachial plexus, and then with the radiofrequency ablation of the brachial plexus. So certain truncal blocks like paravertebral blocks, which can be used again to control the pain symptomatology involving the thorax region. It could be single block, or it could even be place a catheter in the paravertebral space. And nowadays it is very commonly done using the ultrasound, where you can actually see you can see the path of your needle, especially the 2-way needle, into the paravertebral space over here, and then we could guide in a catheter to provide a continuous block, right? So this is a diagram which just says that where is it involved. In the case one, the peripheral tumor, so we can plan for an intercostal block. In the case two, it is including the rib line, not encroaching the nerve root, so we can go ahead with the paravertebral block. So when it includes the encroaches the nerve root, then we'll have to go for erectospinal block, right? And then if it is including the spinal cord, then definitely we'll have to go ahead with the epidural or a IT pump or other. You have to think about other neurosurgical options. Again, coming to the dermatome level in the anterior aspect of the abdomen, okay, we have this the very commonly performed block, that is the transverse abdominal plane block, right? Where you can initially plan for the block or diagnostic block, and then you can plan for radiofrequency ablation as well. So most commonly involved system in case of an abdominal cancer would be the sympathetic system, where the sympathetic system not only is a causative agent, it also maintains the pain in these kind of patients. So wherein we'll have to target those kind of sympathetic outflow, right? So the most commonly performed plexus blocks would be the celiac plexus block or the superior hypergastric plexus block or even the ganglion impara block. So it depends on where the location is and of the tumor and where the and the kind of symptomatology the patient has. So in case of a visceral pain from say the uterus, the ovary, the cervix, bladder, rectum or prostate, we can go ahead with the neurolysis of the superior hypogastric plexus, or it includes mainly perineal pain from rectal or anal cancers or metastatic perineal lesions. We can always go ahead with the ganglion impulse block, and the most commonly performed celiac plexus block is included when the visceral pain is from the pancreas or the hepatobiliary system, or including the small intestine, stomach, spleen, ascending colon, or the adrenal glands. So coming to the celiac plexus block, you know that there are various ways of doing it. We could do it which is traditionally with the fluoroscopy, with the help of fluoroscopy, or with the help of transesophageal. There is also a technique of doing that, right? There's ultrasound guided celiac plexus which can be tried. Each has its own advantages and disadvantages, and again it goes with the experience of the person performing the block and his choice of whichever is suited for him or her, right? Or we can plan for the splanchnic nerve blocks in case the celiac plexus block is not possible because of any anatomical derangement by the tumor per se. Okay, you can go ahead with the splanchnic nerve block. Main important is to know the fluoroanatomy and the anatomy as well to get a very good successful block, and with the always keeping the patient's parameters and safety profile in mind. Okay, so this is a percutaneous technique of celiac plexus block with the help of ultrasound using a curvilinear probe, or it could be CT guided or endoscopy guided celiac plexus block as well. So coming to the, as I said, coming to the splanchnic nerve radiofrequency ablation or neurolysis, again depends upon the condition of the patient and also the survival rate of the patient. The prognosis of the patient matters whichever you, depending on which you choose the kind of technique you want to perform to provide pain relief. All right. So from the pain from the perineal portion, rectal portion, we can go ahead with the ganglion impulse block, because as you know, the sympathetic chain, when it reaches the sacrum, finally fuses to form the ganglion impar of Walther, wherein it can be accessed through the sacrococcygeal disc level. That space, you can just go in. There are various techniques. I'm telling one of the commonest performed technique, wherein you go through the sacrococcygeal space, and when you get that the reverse coma sign as you give in the dye, you can plan for a block, and then you can plan for a radiofrequency ablation. So including for the pain, the sympathetic pain, including for the head and neck and for the arm per limb, we can always try a stellate ganglion block, which again can be performed fluoroscopic, or nowadays it's performed in ultrasound guidance. Okay, so coming to the spine, right? So one of the commonest places for the primary tumor, as well as most commonly for the secondary tumors, wherein they can include the cortex and then finally will lead to pathological fractures. So wherein they'll be presenting with very severe back pain, in addition to the primary pain caused by the primary cancer. So if you're planning to treat the the spinal metastatic pain, one of the good techniques would be percutaneous vertebroplasty. So it is again an OPD procedure, and it can be done safely. And there are reports where the patients have got pain relief as and when it is being done on the table, and then that is could be very rewarding to a patient, if not for 100% relief, but at least say 50 to 60% relief. That goes a long way in a patient suffering from these kind of multitudes of pain pathologies. You can also try for kyphoplasty, wherein you're just trying to improve the collapsed vertebra, which is actually the cause for the pain. So again, intraspinal techniques. So wherein you're delivering the medication into the epidural space or directly intrathecally, right? So how do you actually decide? So life expectancy again is a big factor here. So if it is life expectancy is less than 3 months, you can try for an epidural catheter, which is tunneled or with an implantable system for dealing with somatic or neuropathic pain, or you can go in for a spinal catheter itself to tackle the somatic or the neuropathic pain. But if the life expectancy is more than 3 months, then you can go for something called as an intrathecal trial initially, wherein you see whether the pain intensity decreases by 50% or not. If there is no decrease, then there's no point in placing the catheter. If it decreases, then you go with a trial with the intrathecal catheter. Again, you see after the trial whether the pain intensity decreases with 50% by 50% or not. And if it intensity decreases by more than 50%, then you definitely go for the intrathecal implantable pump. And if not, you have to reassess, and you go back with your assessment and try to involve the multidisciplinary team to manage the pain. So definitely you can see that cost is a factor. So finally, when you want to treat the patient, you have to take care all of these considerations into mind. It's not only about thinking that, okay, I can do this. You may be able to do a lot of things, but at the end, it depends upon the status of the patient in every aspect: bio, psycho, social factors, financial factors, everything, the survival expectancy. All these things should be taken into consideration before we actually jump into a interventional procedure. Because sometimes just with oral morphine, with those medications and the adjuvants, the pain can be controlled. But so you have to really make that decision for the patient, because the patient is already overburdened over here, and it's our responsibility that we should not further burden the patient with all these techniques and financial aspects as well. So you can a simple epidural infusion of drugs also, based on the case and based on the availability of the different materials. This is the intrathecal pumps which I was talking about, wherein the catheter is in the intrathecal space, and then it's tunneled. The catheter is further tunneled subcutaneously, and you have the reservoir which delivers the medications. Of course, it is a technically difficult procedure, and also at the financial level, it is a costly procedure. So you have to take in care of the trial also, and not directly jump into the primary procedure. So what is the role of these early interventions in cancer pain? So there is a rising call for early implementation of interventional pain management in carefully selected group of patients. Evidence is building about pervasive effects of long-term opioid use, such as progressive central sensitization, immune suppression, hypogonadism, cognitive dysfunction, and psychosocial implications. So, and the neurolytics blocks can provide prolonged pain relief, avoid distressing opioid-related side effects, and hence play a major role in palliation of intractable pain conditions. Okay, and long practice WHO ladder can be turned upside down with early implementation of the interventions. As I discussed earlier, we can step down very quickly. So because as you step up, you're going with stronger opioids, and these opioids always have their side effects, and you can see that the opioid has become a big burden, a global burden, and the medical fraternity is struggling to find certain different kind of other supplement to treat pain, so, wherein these interventions can play a big role. Okay. So, right intervention in the right person, by the right person, at the right time and place is the dictum and thing I would want to conclude today's talk with, in order to have sustained and effective results. The aim of the wise is not to secure pleasure but to avoid pain, as told by Aristotle long time ago. Thank you for your patient hearing.
Thank you, Doctor. We can end the session.